you do is actually stand up nice and tall, look straight ahead, march in place a few times for me. Just march in place a couple times and just let your feet relax, okay? That's good. Just relax, okay? The reason why you ask a person to march their feet is you want them in their natural resting position, physiologic position. Sometimes when people know you're going to be looking at them, they might realize, oh, my foot turns out a lot, so I want to turn that in and make it look right. Some people know that. So if you just have them march in place a few times, their body's going to naturally just fall into whatever position they naturally want to be in. So one, that's very important when assessing his posture and all that. But two, so what motions do I want to test at the ankle? Dorsiflexion, plantar flexion,
Eversion, inversion.
eversion, inversion. Let's use the term supination and pronation. Okay, inversion is a there is no bony joint that does pure inversion range of motion. Inversion is a movement of that inward rotation of the foot, but the subtalar joint does not, and it's a pure it's a frontal plane motion about an anterior posterior axis, but you will learn when you get to the subtalar joint does not lie in that pure frontal plane. It's actually a triplanar motion. It lies in between the frontal and sagittal plane, so as a result, there's actually three motions that occur simultaneously at the subtalar joint. And when we combine the movements of inversion, plantar flexion, and adduction, which is what happens at the subtalar joint, we call that supination. And when at that joint you're getting dorsiflexion, eversion, and abduction of the ankle, we call that pronation. Okay, so you'll learn that more in kinesiology. But how are we going to tell him how to do that? We're not going to say pronate your foot. The patient's going to look at you like you have 10 heads on, right? So plantar flexion, dorsiflexion is pretty easy. So Kyle, what I want you to do is go up on your toes for me as best you can. Excellent. I might even ask him to stay up there a few seconds. I can get an assessment of how does he does with his balance, but two, how does he do with, just kind of sustained hold there. Good, relax. Go up again. What's happening to his ankles? A lot of what? Stability. Stability. Does he have it? No. He's wobbly, right? He doesn't do very good up there. Give him a few reps and he'll get there, right? Good, excellent. Dorsiflexion. Can you just kind of lift your feet up off the table? Good. Take a step or two away from the table. There you go. And lift up. Excellent. And relax. Okay. Yes?
What if you had a patient who wasn't very stable?
You could give them a little bit of a hand there. What you want to do, though, is you don't want them... Well, I mean, you see what they do. I mean, if they have a lot of weakness, inherent weakness there, and they're really using their hands for their balance, and they're like leaning over the table to go up, you got to think to yourself, why do they need to deload their body so much to get up on their heels? Is it a balance issue? Is it a strength issue? Remember, this is just the first part of what we're doing here, right?
Well, like, I don't want to ask my grandpa to do this. You know what I'm saying?
I got you. Yeah. So you can ask him to hold on to something there and just see how well he does going up on his heels. It may not be, I mean, if he's going to fall over, he's probably going to, put that leg down right away. This is also if you know your patient's going to have balance. We test balance all the time as therapists. When you test balance, there's a very good likelihood they could lose that balance and fall, right? So when you're doing things like the Berg balance scale and some of the other activities that you do, you need to be on that person right there. Okay? I've had patients where I was like, I don't think they'll ever be able, I'm going to put an object on the floor and see if they can pick it up. I don't think they're going to, so I'm like there with them as they're going down and back up again. Because you have to be, from a safety standpoint, right? Especially if you think, I have a person here who might really lose their balance. I need to be extra careful and be on top of them. Make sure they don't, okay? So for pronation, what we're actually going to ask the person to do, and we'll see if he can do it, is just again, relax your feet for me. Pronation, again, is abduction, eversion, and dorsiflexion. So all I'm going to ask the person to do is, can you try to flatten out your ankles and try to kind of bring them inward towards each other as best you can? Good. And then relax. And can you do that again? So he's pronating his foot. He does a pretty good job of it. Okay. Can you roll your foot so you're standing on the outer edges of your feet? Supination. He does okay with that. Okay. The last thing I might ask him to do now after the ankle movements is his forefoot. So I want to see how his toes do. Can you curl your toes down as best you can? Good. And how about lifting them up as best you can off the ground? Perfect. Okay? So that would be the weight bearing assessment. Quantity, quality, how does that change your symptoms? You've got to be asking those questions the whole time. Okay? All right. For the non-weight bearing portion, I'm going to have him lay down on his back. Let's do this. You can lay back. Yep. Nope, you're fine. Okay. There's a few issues with doing this way, especially for what motion? Ankle. Pull your foot back from me as best you can. What could be an issue here that I'm not seeing actively? What could be, is that full range of motion? If he's gastroc tightness, that could be an issue. So one thing you might do is you might want a small pillow, or even as a therapist, you might just, let the knee bend a little bit and now pull your ankle all the way back as best you can. Good, okay. And relax. Can you point your foot all the way down? Good. For supination, pretty much you just have, can you pull the foot all the way inward for me? We call that inversion, but it's really a supination, right? And can you turn your foot outward for me as best you can? Pronation, but we call that eversion, right? Okay. Can you curl your toes as best you can for me? Down. And how about pulling them all the way back? Good. Excellent. So that is the active movements. Okay. Passively. Passive range of motion you are only going to do in a non-weight bearing position. You can't passively move someone if they're standing on their foot, right? Just for simplicity, let's put that right there. Okay. So what I can do with the ankle is passively dorsiflex the foot as best as I can. I can plantar flex his foot. His calcaneus is hitting the corner of the table, so the ideal thing to do would be let him just barely come off the edge. So now I can go through the full plantar flexion motion. Supination and eversion. Okay? For the forefoot, I can come in and curl the big toe. I can do isolated MTP, interphalangeal joint, and then I can do each of these individually, flexion and extension, if I really feel like I'm dealing with a forefoot issue with the toes. Okay. First, MTP is definitely one you're going to want to look at a lot. Plantar fasciitis, individuals with just foot dysfunction in general. You'll learn about the windlass mechanism and how that pulls on the plantar fascia. And so if they've got limited or even hypermobile, but especially limited motion in their MTP, that's going to be something you might want to work on from a mobility standpoint. So definitely that first toe is going to be very important. Okay? But you can go through all the toes that way, one at a time. The last thing is the resisted movement. So in a neutral position, just kind of right when he relaxes, he's pretty much fully plantar flexed there. So I'm going to dorsiflex him. So he's in about 20 degrees of a plantar flexed position. I'm not taking him to 0. I want him in a relaxed position. Hold, don't let me push your foot down. Assessing dorsiflexors. Don't let me push your foot up. Good. Don't let me turn your foot outward. So that would be supination, right? Don't let me push your foot inward. This is assessing pronation because he is everting his foot and dorsiflexing. Don't let me push outward again. Good. And then at the toes, I can do flexion extension. Don't let me push your toe down. You got there. Good. Just relax. And when I say don't let me push you up, okay, ready? Go ahead. Good. Excellent. As the toes, I just kind of always tested them as a group. So what I'm going to do is don't let me push your toes down. Good. And don't let me pull these toes up. Okay. So you can see extensor digitorum brevis. You can kind of tease that out with just the little toes and the flexor muscle that way. Okay. That's how we do foot ankle.